E na mana, e na reo, e na iwi me na hoe whā, no mai haere mai, tēnā koutou katoa. Ko Helen Nicholson toko ingoa, te tumu whakarai taupua, te wharewananga o tākou. Nō reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. Kia ora, my name's Helen Nicholson and I'm the Acting Vice-Chancellor of the University of Otago, and it's my great pleasure to welcome you all to this very special occasion to celebrate Bruce Russell's promotion to Professor. These lectures are really a great opportunity for all of us to take time out and to listen to our amazing staff and the research that's being carried out across the university. I'd like to welcome colleagues, students and friends from across the university and the wider community. And I'd like to give a very special welcome to Bruce's family, his wife Elsa and Maeve and Lachlan, and his sisters Jacqueline and Julia. As some of you will have heard me say, promotion to Professor at the University of Otago is not something that's easily achieved. And in order to get promotion, Bruce has had to demonstrate sustained excellence in teaching, research and service. Now, as you will shortly hear, Bruce is a neuropsychopharmacologist and clinical pharmacist with expertise in addiction, recreational drugs, and presumably not personally, and serious mental health conditions, including treatment-resistant psychotic and mood disorders. Bruce's research is based on his practice as a pharmacist, and he is specialised in treatment-resistant mental health disorders. So congratulations, Bruce. We're very fortunate to have you as part of our university whānau. And I'd now like to hand over to Professor Carlo Mara, Dean of the School of Pharmacy, to provide a formal introduction to Professor Russell. Nō reira, tēnā koutou katoa.
Thank you, Helen. Kia ora koutou, ko Carlo Mara tako ingoa. I'm Carlo Mara, I'm the Dean of the School of Pharmacy, and it's with immense pride that I am able to introduce Bruce Russell's IPL. We're immensely proud of the things that Bruce has achieved at the School of Pharmacy, and obviously at our competitor School of Pharmacy on the North Island, but throughout his career as well. So Bruce is a true man of the South. You were brought up in Invercargill and came to the University of Otago, did a Bachelor of Pharmacy with honors, and then did your PhD as well. Then Bruce, before that, Bruce actually embarked on a number of different aspects of his career, which he'll touch upon in his IPL, which is very interesting. And he went to Scotland to do a postdoctoral fellowship, and he also worked clinically as a prescriber advisor in general practice. And to this day, Bruce is one of the few researchers in our school that maintains his professional license. So that is a very useful part. He met his wonderful wife, Elsa, in Scotland, and they moved to the University of Auckland, where they both were on faculty there at the School of Pharmacy. And then we were fortunate enough to recruit him down to the University of Otago. And he's made really big impacts since he has come. He's been an excellent teacher, has done fantastic research, and has really filled in a number of leadership positions, including currently being Deputy Dean of our school. So large decision-making roles Bruce has occupied. So it's with great pleasure that I will turn the mic over to Bruce Russell to give you his inaugural professorial lecture, Speed, Addiction, and Psychosis.
That's quite an introduction. Thank you all for coming. There's a few faces which I didn't expect to see, as well as a few people that I don't know, which is not a bad thing, obviously. Anyway, so obviously I'm going to talk about three things, mainly speed, sometimes addiction, and also psychosis, which is, I guess, sort of a long-standing interest of mine. And the speed part of it will, I guess, comes from my own personal interest in just going fast, as well as actually clinical interest in the drug and its effects. So I guess this sort of started, as I said, when I was quite young. So if you look at this, that's me when I was probably about 7 or 8. That photo would have been when I was in Gore, at Gore Main School. And at the time we lived at the top of quite a big hill in the middle of Gore, sort of one of the fewer bigger hills in Gore. is a small town, obviously, which most of you will know. And I built this go-kart, and I was quite pleased and quite excited with myself, and I sort of, gone on at the top of the hill and sort of went hurtling down the hill. To be honest, it scared the hell out of me at the time, but it was also quite exhilarating, and I was thinking that's kind of weird. I didn't expect to be sort of feel quite so high about it as well, I guess is the best way to put it. And that interest in speed obviously persisted. It's the next picture there on the right of me, when I was at high school, everyone else played football and rugby and all these other things. I tried all of those things, but I didn't really enjoy them. I was still really just interested in speed. And I was probably the only kid at my high school anyway who took up speed skating. So I raced obviously people on the ice. I liked going fast, and that was sort of a follow-on. Around the same time, I also got quite interested, I guess, in model aircraft, because I decided when I was going to be older I was going to be a pilot. So I started building model planes, and they were also quite fast. So that photo there at the bottom, that isn't actually me in the middle. That's a good friend of mine called Philip Winter. I'm sort of on the right facing the model and would be Dave Harper's hand, actually, trying to get it started. So they also got really, really fast. So at the time, I was probably, 14 there when that was taken. And those model aircraft, when you're hanging on to them, were still doing sort of 130, 140 kilometres an hour. And some of them were really fast and doing sort of well over 200. And that was a big thing. They were really fast. Again, that sort of goes on with first sitting on a go-kart, and then speed skating, and then flying model planes. And obviously, I sort of, when I saw the movie Top Gun, this, I feel the need for speed, that really sort of resonated with me for obvious reasons. This sort of progressed, I guess. So my father was a mechanic. He worked quite long hours sometimes. But he was always doing something in the garage, in the workshop out the back. So he had a lathe and a welder. I remember him building trailers and working on cars. So I grew up around cars, and I sort of, I guess, had that interest in cars. So I got quite good mechanically. So I guess I managed to build things like model planes. And then about halfway through high school, I guess, most of my friends, I guess I probably wasn't that academic, but I did okay. But most of my friends all started drifting off, and they did trades. So they went away to be, auto electricians and carpenters. One friend joined the army and did electronics and all this sort of thing. So that was quite good, but I wasn't in that sort of top stream of school, I guess, by the time I got to high school. So I sat university entrance because I didn't do enough work in the sixth form, as it was called at the time, to get it accredited. I passed chemistry, physics and maths. Literally just passed them. I got sort of like 52% and things in them. It was just by the skin of my teeth, literally. And I actually failed biology, which is weird when you consider what I do now, and English, which is obviously really important if you're trying to write papers and things. Anyway, so I left school. By then I had my first motorcycle. That's a picture of what I was riding at the time. It's an old Kawasaki triple, for those of you who are interested in bikes, which is probably not many of you actually. But it was quite a fast bike at the time, and again it sort of reflected this general interest in speed and me trying to go as fast as I could on a regular basis. I got more than one speeding ticket around the time I left school, which was obviously frowned upon then, as it probably should have been, and it is now, but it was something else I did to try and go fast. So anyway, I left school before I finished high school. Sorry, I left, that sounds good. I never quite finished high school, so I left school, and I got this job at Edendale, so there's a big dairy factory there. I tried to get a job at TY Point, which is where the aluminium spouter was, because I've been watching my father work with metal all his life, and I was quite interested in metallurgy. I couldn't get a job there, so I ended up working in a dairy company in a quality control lab. And I worked there for a few years, and I sort of built various cars and things. There's a photo there of someone skydiving. I also tried that again. That was with the intent of going as fast as I possibly could. At the time I read somewhere that if you fell flat, you were falling at about 200 kilometres an hour, but if you went head first, you could do up to 300. And that really intrigued me. So I gave that a shot as well. So I skydived, not a lot, but I did it a few times. And I didn't do it as they do now. Mostly people, when they skydive, they sort of strap themselves to someone else and do a tandem jump. I just jumped out of the plane. I remember the first time was we Cessna 172, and the instructor basically said, you have to climb out of the plane behind the propeller, you put one foot on the wheel, and you hang on to the strut like this. So you're standing there behind the propeller, which is sort of, I guess about where the end of that table is, and then when they say let go, you let go. So I did, but the line at the time was, what happens if I'm too scared to let go? And he said, well, I'll just take my foot off the brake, because you've got one foot on the wheel of the plane, obviously, and that's, if it goes round, your foot goes out the back and you have to let go. Anyway, so I carried on with that. While I was at the dairy lab, at the dairy company, I acquired some really, really good lab skills. And I got really quite interested in chemistry, which is obviously one of the few subjects that I'd passed. And also microbiology, so I did a lot of work around that, and I actually ended up going back to night school and sitting those papers again and actually passing them quite well. So I didn't get them the first time, but I did quite well the second time. But I wish I hadn't wasted quite so much time. This sort of theme, I guess, carried on. Obviously, I was still interested in going fast, so I bought a Lotus 7 from a company in Auckland. I modified that quite extensively, fitted what at the time was called Formula Pacific, which is about the same level as Formula 3. So I built one of those engines and I fitted it that, and I raced at club racing for quite a while. Blew it up on a sort of occasional basis. Blew it up once, sort of driving down one of the streets in Inaugural. The clutch came out, took out the bell housing, all the fuel lines, the electrical lines, so I had no brakes. Sort of coasted to a stop from, I forget what speed I was doing, it was something I shouldn't have been doing obviously. Jumped out of the car, and the passenger in the car also jumped out. And he said, oh shit, we better stop it from catching fire because there was fuel leaking all over the place. So he jumped out with a fire extinguisher and he said, where's the battery cable? So he picked up the battery cable and of course it sparked. Then the car did catch fire. But fortunately he had a fire extinguisher in his hand, so I put it out. Anyway, so I'm getting off topic here. So around that time I thought, well, all of my friends again had all gone and done trades, so they all wandered off to Los Angeles. We were all interested in sort of going fast, we had just interest in cars. So we shifted to, or there's a bunch of us actually shifted to LA. So I lived in Los Angeles, I guess, for quite a while. And I got a job at a hydraulics engineering workshop as a general mechanic. As I was mentioned, I was, not too bad with spanner, so I did okay. And I guess this is where I first sort of came across the drug speed. So at the time we were building a series of presses for the American Army. So they were presses basically for building these big artillery shells. So I remember we were sort of working with these drills and things, and we had to shift these big pieces of metal around that we'd been working on with a forklift. And this young man that I was working with, he was about the same age as me. And he was getting really red in the face, and he was working really, really fast, and I couldn't figure out what the hell was going on. Why are you working quite so hard? You worked hard anyway, but he was sort of going up and beyond. And he admitted that he'd taken some speed that morning. And he'd taken some speed, I guess, to try and impress his father, who owned the company that we were working for. So he was working really, really hard, doing quite a good job, but because we're shifting these big plates around with forklifts and things, I felt quite sort of exposed, I guess, and that was my first experience with speed, the drug. And I thought at the time that's kind of odd that you can do that and still do quite a good job, but he was looking, as I said, quite red in the face. He was about the same age as me, so just over 20 and no more. And it was a bit scary, and I sort of always remembered that. So I'll sort of come back to that later, I guess. So after that, we sort of came back to New Zealand, or I came back to New Zealand anyway. I was earning enough to have quite a good time, but not enough to do a lot of travel, and not enough to do what I wanted anyway. So I came back to New Zealand and worked at a different dairy company in Temuka. Again, quality control lab. And my friends had always said, why don't you go to university? And I met a bunch of people that had gone to university, and they thought, well, I wasn't really enjoying what I was doing. So I sold my car, which was sort of a little bit heartbreaking at the time, but I sold it. So I had enough money to pay fees and things, and bought sort of another old car and a big sort of motocross bike, I guess it was. But I had this sort of plan that I was going to do something useful at university. And I thought at the time, everyone I knew was going into medicine. And I thought, no, I don't want to do that at the time. That looks more like a lifestyle choice than a career. And I thought, well, if I do pharmacy, I'll still do okay, but I should still be able to have some sort of a life outside of medicine. I remember having a talk with Brian Robinson at the time, who was head of the chemistry department. He said, why don't you do medicine? And I said, no, I don't want to do that. Anyway, so I ended up doing pharmacy. So I worked all the way through the sort of pharmacy undergraduate program, which is obviously a 4-year program. And I got to the end of it, and I was an adult student, and I think because I was an adult student, I got quite good grades. I did reasonably well. So I then ended up doing sort of pharmacy honours. And at the time, there was this other drug around that was sort of colloquially called euphoria. It wasn't really a problem in New Zealand, but it was a big problem in the States. So there's this guy, you probably maybe just about read his name at the bottom there, called Randall Clark, who'd been to New Zealand a couple of years before. And he was good friends and worked with David Schmier and Rosemary Beresford at the time. And they said, have you got someone who can do some work on this? So that was my honours project. So I synthesised around 7 or 8 different amphetamine analogues, all on the sort of, I guess by the time was at a minor X base, and ran drug discrimination studies comparing them to dexamphetamine. So basically trying to get a dose response curve for each of these drugs. So I had to synthesize them, then characterize them using this sort of, infrared spectroscopy, NMR and all the rest of it, and ran sort of basically dose response curves. So that was my honours project, which was way bigger than you would do for an honours project now. But we got a paper out of it which was quite good. Obviously it was in pharmacology, biochemistry and behaviour. It was quite well cited at the time because it was on a drug which people knew a little bit about but not very much. No one had really done much with the isomers or anything before either. So I finished that in 1991, so this was, I guess, my first introduction, to the stimulants as drugs, apart from my sort of previous experience in Los Angeles. So I think there was about 8 of them, I think, we were synthesised in the end. And so I think I ended up synthesising the dexamphetamine as well, actually. So we did these drug discrimination studies in Neil McNaughton's lab, who's a professor who, I guess, has had quite a big influence on my career. I actually work with him now. He's retired. He's recently made emeritus, but I still work with him on occasion. I hadn't really seen him for years until I came back to Otago, but I work with him again, which is kind of like going full circle from your honours degree back to, working with him as a researcher. Around that time, obviously, I'd had sort of a reasonable degree as well, and I learned quite a lot. And there was this thing called the Yerkes-Dodson law, and I think I learned a little bit about myself. So I think one of those things I learned about myself, if you look at this, it says I'm not a speed reader, I'm a speed understander. So I pick things up reasonably quickly. But where I exist on that curve is about where that blue arrow is. So most of the things that make most people get quite excited make me interested, not necessarily quite excited. And things that make people really anxious and sort of almost fearful and panicky, I find exciting. So I guess that sort of goes along with the sort of persistence with speed, obviously, persisting with motorcycles and persisting with fast cars, jumping out of planes and all these other things that a lot of people don't do, but I do on occasion. I haven't jumped out of a plane for a number of years, I must admit. But anyway, I really like this quote by Isaac Asimov because I also read a lot of science fiction. So I got an internship as a pharmacist in Dunedin Public Hospital, which, as I've got there, was mostly a rewarding job in 1992, which was the year I did my internship. I was quite lucky at the time. I worked with a woman called Rosemary Beresford, who has a reputation, I guess, in her own right for a whole range of reasons. But she was clinically very, very good, and she helped me get set up in, at the time, what was the antenatal ward. So I set up a clinical pharmacy service for the antenatal ward. So I was interested in, I guess, obviously drugs and pregnancy, drugs in general, obviously. But this was a service that no one else in the hospital had done. I'm not even sure that it exists now. I think it was there for a few years. I went up the ward most days. Obviously, if someone is pregnant, you're not supposed to take any drug, and that's what we were trained most of the way through School of Pharmacy. So I spent a lot of time in the medical library learning about pregnancy and child development. That was a huge interest to me, and I was always very grateful for Julia to do that. Different than my sister, sorry. Different name. Anyway, so I did that, and I guess I drifted back into research again because I was always very impressed with Dick Laverty, who was the head of the pharmacology department at the time, who was also very interested in the amphetamines. So he really had 2 streams of research. So he was interested in stimulants, recreational drugs, but he also had a whole other stream of research going along with cardiovascular drugs. So he was a really, really clever man. And I really enjoyed his lectures, so I ended up going and talking to him about a PhD. So I ended up doing this PhD looking at the effects of MDMA, or ecstasy as it's sort of colloquially known, and we were kind of interested in temperature, and also compared this to another drug which is prescribed. So if you look at those chemical formulas there, the top one is the chemical structure of ecstasy, the bottom one is dexphenfluramine, which has been prescribed, or was prescribed for over 20 years as an anorectic. So that was prescribed for weight loss. Just like methamphetamine and dexamphetamine were too at some point. That was a slightly safer version. It wasn't really quite so toxic at high doses, but most of the amphetamines are, particularly to serotonergic nervous system. That's in preclinical models. So I did this PhD with ecstasy because it was a stereoisomer. I had to synthesize that myself. I was always quite proud of that. I've done this series of stereoisomeric syntheses for my honours project, and that sort of persisted into my PhD. I didn't bother synthesising dexphenfluramine because you could buy that off the shelf, but you couldn't buy the S isomer of MDMA. And at the time, Dick Laverty, was kind of interested in the effects of temperature because he'd sort of noticed over a couple of years that he'd been doing these studies that he had real trouble with MDMA trying to get it to be neurotoxic. This was after several years in the winter. So in the winter when he was running his neurotoxicity studies, the drug very rarely worked. It wasn't really neurotoxic. But in the summer it worked fine. So there's obviously this link with the ambient temperature. And around then, I think, must have been not long after that, he actually shifted most of his animal studies over into what was then the Hercus, as opposed to trying to do them in the Adams building at the time. So I had a good look at the literature. I think I spent probably 3 or 4 months reading papers and decided at the end I knew nothing about what I'd read for 3 or 4 months. Hadn't taken any notes, which was kind of dumb, so I guess I learned a big lesson there as well. You need to write notes when you're reading papers. There's no point in reading them. Don't you, Lachlan? Yes. So we did a little bit of work with D2 antagonists, which are antipsychotics, and I noticed that they cause this huge drop in body temperature. And I thought, well, that's kind of interesting, but that's probably what's being neuroprotective. So we started playing with sort of D1 antagonists and agonists to see if that did the same sort of thing. So I was interested in these D1 antagonists at the time. So as I've got there, the D1 antagonist was kind of not a very good one actually. Didn't really prevent dexphenfluramine-induced serotonergic neurotoxicity, but it did with MDMA, okay? So it prevented MDMA-induced dopaminergic and serotonergic neurotoxicity, and that was kind of a big thing at the time. And that comes down to that idea is MDMA really neurotoxic? That ties in with a gentleman in the UK currently called David Nutt, who's a professor over there. He was a scientific advisor to the British government, I think, for probably over 10 years, from the noughties right, I think, until about 2011 or 2012. And he advised the British government about what was safe to use and what wasn't safe to use. And he came out one day and he said, I've just published this paper, it shows that MDMA is actually far safer to use than alcohol. That was a really outrageous thing at the time, and it probably still is. So he was promptly sacked from his position as leading the sort of council of advisors to the British government for saying that ecstasy was safe. But it kind of went along with, I guess, some of the work that we've been doing as well. And he still maintains that it is alcohol causes more damage, it's more neurotoxic than MDMA. That is at the doses we use recreationally, okay? And I guess some of the work I did sort of, goes along with that. Obviously it was published, which was quite good. So around that time I shifted to Edinburgh, which is where I met my lovely wife. And I went first to Glasgow. I didn't go there to meet her specifically, I just sort of came across her obviously. But I went there as a locum pharmacist because while I was here working with Dick, he had a good friend called John Kelly, who was a professor of pharmacology at Edinburgh University. He came out here and I remember having dinner with him one night and Dick having this big conversation about the amphetamines, and he said, well, I did a lot of the early work in the early 70s on methamphetamine. He said, I can remember taking it and riding my push bike and getting on an exercycle and sort of, trying to measure how much energy you were using. And at the time, speed caused a lot of trouble. That was when they first realised that it was a stimulant and it was banned from the Olympics around that time, and he was involved in some of that work. So anyway, I went to Scotland with the idea of picking up a postdoc with him. But until I did that, I worked as a locum pharmacist in Glasgow and then in Inverness for a while. I didn't have any trouble understanding anyone in Scotland, but they had a lot of trouble with my accent for some reason. So anyway, I got this position at the University of Edinburgh, and we were looking at neuroprotective mechanisms at a thing called the Fujisawa Institute of Neuroscience, which was a drug company-sponsored institute within the university. It was quite interesting. I enjoyed the work, but I was only there for about a year. As I said, that was where I met Elsa, who I've subsequently married. But I guess one of the things with it, because it was a drug company-sponsored research institute, what you did was you did monthly reports like you would for any other drug company. You didn't publish anything. And I think because I was a little bit interested in Elsa, the boss didn't look on that very kindly, so my funding magically ran out at the end of that year. So I then went and worked as returned to being a pharmacist, and I went and worked for the Midlothian Healthcare Cooperative. So I was a prescribing advisor for around 10 GP practices on the outskirts of Edinburgh. I did that for about a year. That was really a position that came about sort of fortuitously, I guess, because it was about the time that the funding ran out. And that really was a maternity cover position. It was interesting, but it wasn't really me. There wasn't really any neuropharmacology in it. was a job which paid the bills, but it wasn't me. And it said this other job came up as a specialist pharmacist at the Forth Valley Hospital, or Forth Valley District Royal Hospital, I think it's now called. And just to show that we've come a long way, at one time it was actually called the Stirling District Lunatic Asylum, this place that I went and worked at. Obviously you can't call it that now, but that's what it used to be called. And I have very sort of fond memories of working there at Bowsdyke Hospital, in particular at Trice Park and Trice View. So Trice Park was a long-term rehabilitation ward for people with chronic psychosis who hadn't responded well to clozapine, or who needed clozapine, which is a drug that I'll come back to later on. I guess it's probably one of the best jobs that I've had, because certainly the best job as a pharmacist that I've had, because at the time you really were part of a multidisciplinary team. So my signature on the piece of paper was just as important as the consultant's. It was usually me that picked the drug and the doses, but I was involved in the diagnosis. So we worked really, really closely, and I quite enjoyed that. There was also psychogeriatric wards, obviously, acute wards, and this forensic ward that I've been working on, as well as the learning disability one. So I was there for quite a while. I quite enjoyed it. One of the things I did discover was I was sort of back to bikes by this time, and I bought this sort of Kawasaki ZX9R. So I used to commute from Edinburgh out to Falkirk, which was quite good. It was about 40 miles each way, sort of miles, not kilometres. It was a big bike, it was quite fast, it didn't take too long. One thing I did discover was that I sort of became quite famous for wearing leathers to ward rounds. And if you're working in community mental health teams or acute or psychogeriatric wards, if you're wearing leathers, you gain instant credibility with the patients, okay? Because you're not standing there in a white coat. You look like anyone else, and they're always interested in the bike. So I could have some really, really good conversations with patients and give them really good feedback, and they would tell me pretty much anything that I asked them. So that idea of riding a bike at the time was hugely important, and I managed to get really, really good relationships with patients, and obviously with the practitioners as well, so the psychiatrists on the wards. It was good. As part of that job, I also taught pharmacy and nursing students from Stirling and Strathclyde, which is a big university in Glasgow, so that was part of the role. So I began teaching again there, which was quite good. So after that, I was back to New Zealand. I also got a postdoctoral position at Auckland University, or University of Auckland, and around that time, the new School of Pharmacy had just been set up, and they were looking for lecturers. John Shaw, who was from Otago, set up the school, and I emailed him when they sort of advertised this job. And he very kindly gave me a job, even though I didn't have an extensive publication history, but he saw, I guess, some value in me. So we shifted back to Auckland, where I met Professor Rob Kidd, who I guess was my next mentor after Dick Laverty had been. So at the time, this is 2005, 2006, there was these things around the streets called the party pill drugs. No one knew anything about them. Chemically, they were just similar to the amphetamines, so they weren't covered by the so-called analogue laws. So you could sell literally half a dozen different types of these drugs. You could put them in capsules yourself and sell them in corner dairies, sell them in liquor stores, all sorts of places. And they were sold in New Zealand, as I've got there, from 1999 to 2007. So they were a big problem for the New Zealand government for quite a while. Initially, they looked quite good because they didn't cause huge amounts of addiction. They didn't cause significant problems. There was a A&E physician in Christchurch called Paul G, who sort of managed to get his knickers in a lot about them. He put a lot of articles in New Zealand Medical Journal and said these things are toxic, they're not very good. And I guess if, like any other drug, if you take enough of it, it's not good for you. And he sort of first brought them, I guess, to the media's attention as being potentially dangerous. But I went back and looked in the literature at the time, this was just after I shifted back, and no one had ever published anything on these. There was one paper which had published some data around human use of BZP, and that really was just looking at sort of low doses and its effects. So that became, I guess, my sort of mission at the time was to, what can we find out about these drugs? I've got a picture of Matt Bowden there. Matt Bowden was called the Party Pill King, okay? So he basically established these drugs as a big thing in New Zealand and Australia and the UK and the States and in Canada too, Carlo. So he set up shops in all of these countries. He made a huge amount of money. But he did this, as he said, to try and get people away from P. So they were, or methamphetamine as it was called at the time, and still is, P for pure. So he said this is a far safer version of methamphetamine because it doesn't cause anywhere near the issues that we have. If I sell it legally, people aren't abusing it quite as much, which was quite true. So I guess, this is sort of a sidestep, sorry. This is something else to do with my interest in speed. This is an aside, okay? So this guy here, Jarno Saarinen, he's the only Finnish rider to have won a MotoGP World Cup. And he's the first person to, as they say, get your knee down. He's the third person in that thing with a clover on his head. You can't see it in the picture, but he does actually have duct tape on his knee. So now when we ride motorcycles, you use your knee as a gauge to how close to the road you are when you're going around corners quite quickly. He was the first person to do that, I guess, as part of the racing circuit. Anyway, sorry, that's an aside. Oops, I'll go back a step. So I guess the thing with these drugs is, what are we going to do with them? And I've met Rob just after I'd sort of written some grants. Rob was the head of the faculty at the time, or the division here as we'd call it, and he was a psychiatrist. He was also quite interested in them, so he was very good and supported me in all of this research that I subsequently did. I can remember going to Matt, I emailed Matt Bowden and I said, I'm going to do some research with these drugs, can you help me please? I need to buy some and I don't want to buy them off the shelf. So he said, sure. He said, just come up to the house and I'll give you some. So I thought, oh, okay. So I went to this huge house in the middle of Takapuna and he said, which ones do you want? And I said, well, just BZP and TFMPP at the time, which is trifluoromethylphenylpiperazine and benzylpiperazine. So he said, right, how much do you want? And I said, I don't know, 100 grams. He said, how about these? So he gave me 2 plastic bags with about 500 grams in each and said, here you go, will that do? I said, that's heaps, thank you. So I've got a very clear memory of walking out of this house in Takapuna with 2 bags of white powder in my hands, looking over my shoulder and wondering where the police cars were likely to be. But the drugs were legal, okay? So it was kind of scary and it was an odd thing to do. I'd taken one of my PhD students with me, who was also looking over her shoulder wondering what the hell was going on. But I remember that very clearly, obviously, and it had quite a big impact on me. But Matt still does some of this work. He still likes to try and push the idea that we should have safer drugs than what we currently use and abuse. I spoke to him actually just last year over Zoom when I was looking to buy some MDMA. That was for some other drug trials though, okay? I said, do you know who's making the stuff at the moment? But I'll come back to that again later on. So I just did that one. My ongoing interest in speed, that nice blue ZX9R that I showed you in the previous slide, I actually wrecked that in about 2006. So I thought, well, I actually broke my collarbone at the time. I punched it, broke a few ribs and punctured my lungs. Rang Elsa from the back of the ambulance. She said, what's wrong? I said, I'm okay, I'm just a bit sore. So after I got over that, I then bought another motorcycle, so I bought a faster one. So I bought that red one there you can see there. So that was around 200 horsepower, weighs 200 kilos. First gear is good for about 160 kilometres an hour or 100 miles an hour. That's first. It's got 6 of them. And I subsequently wrecked that. So as you can see, I did what they call a high side. So the high side goes along with drugs, obviously, or drug abuse. So what's going on there is a high side. You'll see it again in a minute in the GIF. It'll start again, I hope. So just there, the rear tyre started to slide. Slided up the rear shock absorber. It stopped sliding. The rear shock absorber is really compressed and it springs back and it throws you off the bike. And that's what's called a high side because it throws you over the handlebars. So when I did that, I rang Elsa again from the back of an ambulance, said, I'm a bit sore again. She said, what have you done? And I said, I'm not sure, but they were taking me into Waitemata District Health Board. So I did an x-ray, I'd sort of broken a few more ribs, Achilles tendon, and obviously smashed my left humerus. So that is my left humerus you can see there, with all those screws in it. That sort of goes along with the screws in my collarbone and a bit of wire I've got down here. Anyway, that's an aside, so I wrecked that one too. So what do we do about this? No one had done pharmacokinetic studies. No one had drug any sort of proper mood studies about what sort of effects the drugs have on your mood. No one really had a good idea of what they did in the brain either. There was 1 or 2 papers around showing that they probably induced dopamine release. And at the time, there's a PhD or a potential PhD student come to see me who actually did do a PhD with me, obviously, Ushtani Antia. She's now the regional scientific manager, I think, for regional manager for Boston Scientific in Queensland. But at the time, we had to do some studies. We weren't quite sure what was being sold, so we thought, well, we'll have to do a little bit of dose response investigation ourselves. So how much do you want to take? And obviously you can't do that with the PhD students, so I took some of it. My collaborator at the time, Malcolm Tingle, whose name's just before mine, also took some. So we did sort of a little bit of dose response work with these drugs. Everyone else was taking them. Obviously they were legal at the time, so we knew they were reasonably safe, so we just started off with 1 or 2 low doses. But it was kind of a weird thing to do because I said no one had published this. How else do you find how much to give someone in a clinical trial? You need to give someone enough so you can do a pharmacokinetic study, You need to give them enough that you can actually measure it in the blood. So we were taking our own blood samples. Or actually Elsa took some of them. So we came up with this idea of what was a reasonable dose. You know, they said that there was around 100 milligrams in most of the capsules, but some of them had up to 200 or 300 milligrams. So we developed an assay. Ush did the work, validated the assay, and we ran these pharmacokinetic studies with groups of sort of 15 people in them. So BZP had an elimination half-life of around 5 hours, 6 hours, which is not bad for a recreational drug. It's not like cocaine where it's only lasts 20 minutes, but it's not as long as methamphetamine, which lasts for 7 or 8 hours, and you definitely don't want to take that. Malcolm had a human liver tissue bank, so we also did some liver enzyme studies. So we ran liver enzyme assays against these drugs to find out which enzymes were metabolizing them. As you can see there, I've got CYP2D6, 1A2 and 3A4. CYP2D6, for those of you who don't know, metabolizes probably about a quarter of the drugs that we take clinically. CYP3A4 takes around half of the drugs we use clinically. So this drug, TFMPP, is actually an inhibitor of all of these drugs that we use clinically, and that was quite good information for the clinicians to know. TFMPP had sort of a slightly different effect. By then I bought another bike and decided the track days were far safer, so I just did my racing on the track as opposed to what I shouldn't have been doing on the road. So that was what I bought next. But Ush helped an awful lot. She was a great student who worked quite hard. That's another student, that's Joanne Lynn. So Joanne Lynn is now a lecturer at the University of Auckland. This was her honours project, was actually doing some of these dose response curves or dose response studies. So BZP had the same sort of effect as most of the stimulants, certainly dexamphetamine, increased blood pressure, heart rate, and it sort of elevated your mood around the same level. Just not quite to the same extent, and it wasn't quite as potent as the other amphetamines, and it was also obviously legal. Okay, so Joe did that. There was another student at this time called Reem. There's a picture of Reem later on. Reem did some other stuff. We ran a study with TFMPP. This was, I guess, part of her honours project as well. TFMPP was different. As I said, it inhibits the metabolism of CYP2D6, okay, which, as I said, metabolizes around a quarter of the drugs we use clinically. And I thought, well, we did these drug discrimination studies and used profile of mood states, sort of standard clinical rating scales to decide what they were doing to your mood, how long the effects were lasting. And we decided that, now looking at the data, it was kind of stimulant-like, but also made people a bit dysphoric, made them a bit confused and a bit bewildered. So it was more like, say, some of the serotonergic stimulants that we use or are used and used. So more serotonergic certainly than, say, ecstasy or MDMA is. At the time, again, I know from personal experience that I'm a poor metabolizer, so I have very low levels of CYP2D6. I discovered this as an undergraduate student. I did a study with Sompon Wimmelrook in 1991. So I know that clinically I'm a poor metabolizer, so I thought, well, I'll take some of this and see what happens. Might seem like a silly thing to do, but as I said, remember, thousands of people were doing this on a regular basis most weekend. So I didn't feel as though I was sort of doing anything too daring. I knew it wasn't neurotoxic. So I took some, and I told one of my other PhD students, I said, you have to keep an eye on me at the time. And at the time, she had her fingernails painted sort of bright yellow. I remember being quite fascinated under the influence of this drug by these bright yellow fingernails. They were literally glowing gold, and I had trouble not watching them. So as a poor metabolizer, TFMPP did have some effects that most people wouldn't appreciate. As I said, I'd taken a low dose of it, so I was kind of okay. It was a weird experience at the time. The drugs were also sold in combinations, obviously BZP in combination with TFMPP, more like dexamphetamine, but had feelings on, reduced feelings of self-confidence, I guess, is making you feel a little bit lost, depending, I guess, on whether or not you're a poor metabolizer. So Joe and Reem did some of that work. There's a picture of Hee Sung there. It's an old picture, sorry, Hee Sung. And Louise Curley, they were also students of mine. Louise is now a lecturer at Auckland also. Hee Sung's sitting up there in the audience. She works in the School of Pharmacy down here at the moment, which is quite good to have her around. So Hee Sung was very, very good at recruiting subjects for these studies. So she did a lot of EEG work. We looked at a thing called the P300 wave, which is what they call an event-related potential. So you put an EEG cap on someone's head, and you look at the P300 wave, which is basically the measurement of it's the time it takes you, I guess, to evaluate some sort of a stimulus, okay? The P300 wave is actually also, you won't know, the P300 wave is actually also something they're looking at if they polygraph someone. So when they take a lie detector test or a polygraph, they look at the P300 particularly. If that's delayed, there is some, I guess, evidence to suggest that someone is lying, so that's what they look at in a polygraph as well. Anyway, so we've got there BZP and TFMPP, but not the combination affect the P300, similar to dexamphetamine. TFMPP reduced interhemispheric transfer time, and transfer time between the two hemispheres, again, for those of you who don't know too much about the brain, you have two hemispheres, a left and right. The major white matter fibre tract is called the corpus callosum. You can measure the time it takes to cross that from one side of the brain to the other. TFMPP actually reduced interhemispheric transfer time, which we didn't expect because we thought would make it slower because it would slow down your ability to think and respond to something, but it actually reduced it. We didn't expect that, and it had no effect on reaction time. Louise did some MRI work, obviously, so BZP decreased activation of the inferior frontal gyrus, the insula and the occipital regions, and TFMPP also had some effects. We characterised these drugs from a pharmacokinetic viewpoint. We found out what enzymes metabolised them, what sort of drug interactions they were likely to have, and we also looked very carefully at EEG effects and the MRI effects. The consultant that I mentioned before, Paul G, was very worried that they were potentially causing seizures, and they did in fact do this in some people. But I think that was a result of polydrug use rather than those drugs on their own. So getting back to speed again, I guess in this case, speed or P for pure or methamphetamine, whatever you want to call it, and addiction. I had this idea that if you look at people who use opiates, we use what they call methadone maintenance treatment. That really maintains their addiction. So if they're taking methadone, they don't have to commit crimes to, I guess, purchase and use an illegal drug, okay? So if we can do that with methamphetamine, if we can do that with the opiates, why can't we do that with the amphetamines as well? Because P is a big problem, obviously. So I started talking about this trial using methylphenidate as a replacement therapy, because pharmacologically it's the same as the other amphetamines, just like methadone is to all the opiates. And I had a little bit then to do with this psychiatrist called Wayne Miles, so we set up this study where we tried using methylphenidate to decrease the amount of methamphetamine that people were using. So we recruited a bunch of people who we knew were meth addicts that all come through the Community Alcohol and Drug Centre in the middle of Waitemata. We did drug testing on them to make sure that they had been using it chronically, and we gave them a dose of methylphenidate or Concerta, which is a slow release form of methylphenidate, to see if that relieved their need, I guess, to consume the drug. We did this trial for over 20 weeks. The downside of it at the time was we didn't really use a big enough dose, and I was kind of suspicious of that because 54 milligrams is what you would use for an adolescent to try and manage ADHD. If you're trying to manage someone who's using sort of potentially half a gram to a gram of methamphetamine a day, that's not enough, and that proved to be the case, but I guess at the time it proved sort of a point that you could use this drug safely to try and help treat someone with methamphetamine or P addiction. I tried at the time unsuccessfully to get a couple of grants from the HRC. At the time I applied for the HRC 1 year and they said, it's good, but if you fix it up, put it back in again, we will give you the money next year. So I fixed it up again, put it back in the next year, and it didn't even get past the first round. For reasons which are unknown, but that's, I guess, the nature of funding. Also tried the Prime Minister at the time because they were advocating that we'll support money into research around this. And the Prime Minister and his, I guess, cohort at the time didn't want to have anything to do with the study. I think that's one of the problems with drug addiction is it tends to be looked at as a law and order issue. It's not looked at as a mental health disorder. So people think we can fix this if we can make the laws tight enough and stop the drug being imported and used. But you can't. It's never worked anywhere else. Prohibition has never worked for alcohol either. That's another car that I purchased at the time. For those of you who don't know, that's a Subaru WRX. It's quite fast. I needed that because I had sort of big hairy dogs at the time that I was carting around. These big hairy dogs are also quite fast. Reem, who was one of the students before who did a little bit of work with TFMPP, did some MRI studies, as did Joe. They both did PhDs of this, and this was, I guess, we looked at the people who we'd recruited into this trial for methylphenidate as a replacement for methamphetamine. Didn't really work very well, but we did find some interesting effects. This is always, I guess, one of the good sides of when you're recruiting a trial, if you're recruiting addicts or people with an addiction. If you believe the popular press, methamphetamine rots your brain, causes big holes in it. We recruited a bunch of people for this trial, we put them all in the scanner. They all wanted to see photos of the brain when they came out of the scanner. methamphetamine doesn't cause brain rot. It doesn't cause big holes in your brain. If anything, in this case, we actually found it made the striatum, or the putamen, a little bit larger. We weren't really sure why at the time. We had this idea it was potentially some sort of inflammatory response, but we didn't really know why and didn't get a chance to pursue it. So we published that, obviously, and we found that methylphenidate actually helped people function relatively normally, even though it didn't decrease their need to chase P or methamphetamine. It did actually mean that they could function sort of and complete, in this case it was an event-related task in the scanner, pretty much to the same level as you and I could do it. So it did have some effects, definitely, and it was potentially useful. We just couldn't get the money to do anything else with it, which was a shame. Reem is now, I think she's just applied for a promotion to an associate professor in university in Dubai. This was a study which I hadn't intended to do. I'm running out of time, aren't I? It's nearly 6:15, sorry. Grace, photo on the right, at the bottom there, comes for me. She was interested in opiate addiction. She'd worked as an opiate addiction counsellor for a number of years and wanted to do some research around this. So we recruited people who were taking methadone, in this case, and ran them through a neuropsychological test battery to see what sort of effects methadone was having versus those who weren't taking methadone and who were also addicted to the drugs, or in this case opiates obviously, or heroin. And we found that the methadone actually helped them again perform at a relatively normal level versus not taking something as a substitute. So I'll try and go a bit faster, I'm taking too long. Please bear with me. This is Sanya Ram, who's a lecturer at the University of Auckland as well. He's also interested in what they call cognitive enhancers. These are drugs which people are known fairly widely to take, certainly in other parts of the world, certainly in the States and in Canada. We were sort of kind of suspicious of people using methylphenidate or Ritalin, whatever you would like to call it, in New Zealand as a cognitive enhancer. That's to improve their performance around exam times. I tried running this survey across Otago at the time, but the people at Otago, where I now work, weren't too keen. They said you can't ask these students that are using an illicit drug. It could potentially get them thrown out, even though it was going to be blinded. So we just ran the survey at Auckland anyway, and found that around 1 in 12 students, this was sort of 7 or 8 years ago now, were using stimulants to improve their performance in exams. That's quite a low number compared to those overseas. If you look at, say, some of the American universities, you'll find that the survey is reporting sort of 20 to 30% of students use them. There is some, I guess, ethical and social acceptability around that. Ethically, people think, you know, should I be using this drug? It's a little bit like taking steroids if you're going to compete at the Olympics. Should I be taking this drug for improving my exam performance or not? If the drug is not going to cause any harm, is that really such an issue? So we also looked at things like that as well. So that was also quite an interesting study. Anyway, this is a quote from Jeremy Clarkson, who I also quite enjoy, obviously. Speed has never killed anyone. It's a little bit like the quote about gravity, you know. Gravity is not what kills you, it's a sudden stop at the bottom. It's the same with speed, obviously. It's, you know, when you suddenly stop, that's what does the damage. Again, that's my bike. Psychosis. Remember back to that slide, I said I worked for a while at Bells Dyke, or Trice Park, Trice View. So I was really interested in schizophrenia because I worked with people who had schizophrenia that didn't really respond to standard treatments. It's a very disabling disorder. People have quite marked so-called positive symptoms. They suffer from hallucinations, can be quite thought disordered. A small number of them can be aggressive, not all of them obviously. They have quite a lot of negative symptoms as well, so it's really flattened emotional response. They suffer quite badly from apathy and anhedonia, so they don't really see any pleasure or find any pleasure in general life. And they have quite marked cognitive symptoms, so they aren't very good at focusing on a task. So combined with apathy and anhedonia and that inability to focus, they don't always see a lot of point in taking their medicines because they don't really find any pleasure in life. So I guess adherence or concordance, as we call it now, I think it's the current term, is an issue in those patients. The other big issue we have is only 2/3 of the people with schizophrenia, the psychotic disorder, actually respond to the drugs which we would normally use. And as I said, I had a really good relationship with some of these patients who didn't respond to the first-line antipsychotics. So I was always really interested in trying to work with a group of them. So in this case, we ran yet another study, and we looked at, I was particularly interested in this drug called clozapine. Clozapine we use for treatment resistance. It's the only antipsychotic we have which we know decreases suicidality, decreases rates of independent living. Maybe yawning, that's a bad sign. It decreases aggression, but it has this sort of long list of side effects, but it does work really, really well. So I wanted to do a study and find out why only some people responded to clozapine, because even though we use it a lot, not everyone responds to it either. So a third of the patients with schizophrenia or psychotic disorder get prescribed clozapine, but only about half of them respond to it really well. The other half don't respond to it very well, and some don't respond to it at all. So we ran this study looking at patients with treatment-resistant schizophrenia. Found that we sort of tracked down around 156 of them. This was in Auckland. It's very hard to do a study of this size in Otago because we have a smaller psychiatric population. Obviously, it's a smaller centre. We managed to recruit 64 of them who met all the inclusion criteria, and because I was interested in MRI, we put them in the scanner. We found this group of people, as I've got their ultra-treatment resistant schizophrenia, that is the people who don't respond well to clozapine. They had this sort of decreased grey matter density compared to controls, which wasn't really a huge surprise. But what was a huge surprise was if you look at this other group, sorry, this is a picture of a postdoc that I worked with at the time called Valerie, who's now in Kubrick, in Wales. Those who do respond well to first-line antipsychotics, their, I guess, grey matter volumes are quite normal. They're the same as the controls. Those who are treatment-resistant and ultra-treatment-resistant aren't. That was kind of a surprise at the time because you can talk to a lot of clinicians and they think that, well, not all of them, sorry. Some think that the antipsychotics are neurotoxic over long periods. Because if you look at someone with schizophrenia, you find that their ventricles do become enlarged and they do have changes in grey matter volumes. But looking at our study, we only found that in the treatment-resistant group, not in those who responded well. So that, I guess, was a marker of potentially who might respond. These groups, just in case you're wondering, were all matched for age and illness duration and medicine, and also their, what we call their rating scales. So they all had around the same level of response to the drugs we were using at the time. So Val did a lot of work around that. We did a thing called diffusion tensor imaging, which looks at your white matter microstructure. It looks at the integrity of the white matter, and found that those with treatment resistance, again, had the sort of altered or sort of poorer connectivity between the left and the right hemispheres, and we thought, well, perhaps that could be a biomarker of treatment resistance. And again, so we published that, and that was quite a nice result, and that was kind of a surprise as well, because we didn't expect that. And we thought we would see that more in the ultra-treatment resistant group, that is those who don't respond to clozapine either, because by nature, they're a harder group to treat. Carolyn did a little bit more work on that and found another region as well called the superior longitudinal fasciculus. And again, that was different in those with ultra-treatment resistance and those with treatment resistance. And that wasn't a huge surprise either, because those areas along that superior longitudinal fasciculus from one end to the other, they're the areas that sort of, I guess, responsible for perception and auditory centres. That's probably why they had sort of slightly more severe auditory hallucinations, certainly in the first instance. And that's Carolyn, as I said. She's now a lecturer in, she just got a lectureship in Wales in the Department of Psychology. If you're doing imaging, you can also do other interesting things. So you can actually look at glutamate levels in patients. So you can measure the metabolites in the brain of patients without sedation while they're just lying there in a scanner. So we're very interested, obviously, in glutamate, which is, well, I guess, one of the major neurotransmitters in the brain. And again, we found differences in patients who found differences in treatment groups, which reflected, or made them specific, I guess, for one particular type of treatment than another. And decided those with ultra treatment resistance, that might make them may represent a marker of response to clozapine. So again, that was really, really useful, I thought at the time, and that's a picture of Meg, who's invited me to give a talk at the end of the month. Actually, I need to write that as well. Straight roads, fast cars. Obviously, research by nature, you have one idea and you think, well, I'll solve this and then that'll be good. But there's always all these twists and turns in the middle. So what you set off down one path trying to find or prove, you often get diverted. So you end up making all these sort of diversions and finding other things which might interest you, which is why I quite like this quote about straight roads being for fast cars and turns are for fast drivers. And as I say, any fool can drive fast in a straight line. It's the corners that get you. So to date, if you're looking at psychosis, grey matter volumes, only those with treatment resistance, and ultra treatment resistance shows significant widespread grey matter loss. So that was a surprise because, if you read all the textbooks, they say everybody with schizophrenia has grey matter loss, and that certainly wasn't what we found. We also looked at sort of white matter changes, obviously, in those with treatment resistance had significant changes, but surprisingly, first-line responders, again, were the same as controls. Again, that reinforced the idea that if you responded well to one of those medicines first up, you didn't necessarily have all this grey matter loss as well as white matter loss. And as I said, we found a marker, I think, for ultra-treatment resistance, that is those who wouldn't or don't respond well to clozapine. So overall, these are all quite useful biomarkers. And it's an area I'd sort of love to continue with. Some of the data we collected at the time is now being used in bigger studies. There seems to be a trend these days. Not everyone works alone, certainly within any one institution. So I was approached by a woman called Kate Merritt, who works at University College of London. She said, could I please have your raw data? I'd like to include it in this bigger data set. So this was published in JAMA Psychiatry, which is, I guess, one of the bigger journals in the world, just a couple of years ago. So my data was included in this big study, and again, it sort of really supported work that we had found, so I was quite pleased with that and for that. I said it's a reflection, you start out doing things on your own, but often your group grows and your data, if you collect the data well, can be used in other studies. So currently, I guess this is a bit an end to it, sorry. I'm the principal investigator, so I work with a guy called Associate Professor Richard Linscott. We're looking at sort of predictors of psychosis, so those who might become psychotic. because I'd really like to find out why people become psychotic in the first instance. And that's easier to do, I guess, than look at people with treatment resistance, certainly in a smaller population centre. I'm also looking at the effects of ketamine, so ketamine on treatment resistance. So we know that people with treatment-resistant anxiety respond to ketamine well. Not everyone does respond to it, and we don't know why. So again, I'm doing an imaging study trying to work out what's actually going on in the brain, why some people respond to ketamine and some don't. And I'm also, I guess, an associate investigator on a whole range of other studies. Work with Liv. Where's Liv? Liv at the back. Liv, I guess, her and I sort of co-lead this group now called Image Otago. I was very lucky that Liv actually came to Otago, actually. So Liv has a study called Breathing Perception and Anxiety, so I'm helping her do that. Although I think she's really just doing it mostly on her own with me watching mostly. Also work with Neil McNaughton, as I said at the start of the talk, you sort of go full circle, so I'm now working with Neil again. Working with Dirk de Ridder, who's here sometimes, and in Belgium the rest of the time he's a professor of neurology. And also with Paul Glue, so we're interested in MDMA. So again, I've come back to MDMA, which is, I guess, about where I started this talk. Certainly when my research career began anyway. Currently, and that's what I'm currently writing, if you're interested. I guess in the way of acknowledgements, there's a huge number of people, as I said, you start this stuff on your own, and your group just grows, and you can't do it on your own. Sorry. So participants and patients, there's been a lot of them, obviously family and friends. I've had a huge number of collaborators, both here and in Auckland, some of who are very close. Paul O'Donnell, who is not here, he's an IT systems manager here at the university. He first helped me, I guess, provided me with the ability to do some of the sort of large-scale data analysis. So he did that while he was employed here at Otago. He actually flew to Auckland and helped me set up a computer cluster for doing MRI data analysis. I paid him for it at the time via the university, but he's sort of been an old friend of mine. He was an instrument technician here in the School of Pharmacy when I first started my undergraduate degree. I've had obviously some very, very good past PhD students, and I have some very good ones currently. There's certainly far too many to name. So there's all these people who've supported me. I guess that's about it. I quite like this quote as well. So I'm getting older, obviously. I hope to pick up speed sometime soon. It's just not quite worked yet. That's Bert Munro, obviously, who set an official land speed record when he was 68. So that's it. Thank you. Thank you for listening. A little bit over time, sorry.
Oh, no, it's a fantastic talk. Thanks very much for that. Don't go too far. A fantastic IPL. It was really fascinating to see as your career progressed and how you started with MDA and you just came full circle and you came back. And it's also good to know when probably most people in the audience have been scanned by you at some point. So it's good to see where our data was actually used.
Yes.
For that as well. So it was a very important summary of your work. And it was fantastic, and I actually learned a lot, even though I knew a lot of it going into it. And I like to believe this quote, but I'm not sure it's actually true.
It is.
Well, it's a true quote,
It has
but
to
I'm
be,
not sure
yes.
if it applies to me.
Thank you.
So before you go, I would like to take this opportunity to present you with a small token of appreciation from the university on achieving your professorship. So congratulations.
Thanks, Carlo. And thank you all.